Hi, everybody. It's Susan Clinton and Erica Mello, and we are here talking about Tough to Treat again. Welcome to this week's or this month's episode that we're doing. It's going to be number 125, which is hard to believe that we've been after this for 125 times, bringing
Oh
this to
my
you.
God.
Seems crazy, right? We
Yes.
want to remind everybody that we have a website, toughtotreat.com. Come in, join our newsletter list because that's where you get all the information about what's going on with Tough to Treat and the pertinent things that we're up to and what we're doing. This is the best way to find out how to stay more involved with us and with the podcast.
And we also have some great clinical pearls and PDFs on persistent pain and sleep, and a lot of great clinical pearls in there. So feel free to hop on the site and
Mhm.
and check us out.
Yes, and don't forget, we still have our premium subscription. Uh, it's toughtotreat.supercast.com. For the very
Hmm.
small price per month, you get a premium podcast of an interviews that Erica and I are doing with the experts leading Tough to Treat in the field, as well as show notes and offers to come in and talk with us personally in our
I
Ask Us
know.
Anything portal. That's absolutely ridiculously dirt cheap mentoring.
Totally. It's
Take
private
advantage
mentoring
of it.
session.
Yeah, take advantage of it. And and if you can't come in live to it, you can certainly leave us questions and we will give you in-depth answers through our subscription portal.
In the
And we
portal.
would love
Yeah.
to have you there and be part of us again.
And
Toughtotreat.supercast.com. Don't miss out
and
on
you know the
this.
thing, yes, yes, yes. One last thing, Susan. The people, whoever mentors that we have, a lot of people post questions in forums and groups and things like that. But it's not the same as when you're live with someone on a Zoom call or a virtual meeting or something, and you get your questions answered quickly. Whereas if I had one of my mentors, if I have to go in and ask questions, I can wait a long time, for things to filter through the networks. And I think with
Mhm.
the membership, it's a very, very close access to us. And I think that's why it is so, so valuable, right? So,
Right. And
um,
popular. So come in and be part of us. Work with
yeah.
us. We want to work with you. That's why we do this month after month. Thank you.
Mhm.
Enjoy the podcast. Hi, everybody. Welcome to Tough to Treat. This is episode number 125. I am your co host, Susan Clinton, with my co host, Erica Mello. Welcome, Erica.
Hi, Susan.
Yes,
Thank
we're
you.
excited
How
to
are you?
bring you podcast number 125, and let's dive right into it. I
Let's
know
do it.
everybody in our world loves to listen to how we look for and find various drivers for
Yes.
problems. I'm going to tell you the story of a ballet dancer. I have seen her off and on through the years. She just got in touch with me recently. She's out in an intensive before she moves on to her company position. And so she wanted to fill her summer with some extra work. She is a lovely young lady of the age of 20 and has had some issues, with some nerve pain down the back of her legs. She's also had some issues with, feet issues with strengthening and, maintaining, some balance issues and some, just some different things through the years, but nothing really big, nothing terrible, and stuff that can always be taken care of pretty easily. She got we did some virtual work together because she got in touch with me because she was having some persistent problems with her left hip. And she told me that she injured it. She felt like the injury that this most recent one occurred when she was in a half kneeling position in jazz class. So the left foot was on the ground, the right knee was on the ground, and they were doing trunk circles. So if you can imagine the whole trunk moving around and the balance and control you need to have on both hips for
Yeah.
that type of movement. She said she felt like something gave. She said she doesn't know if it popped out of place, what it was, but she knew that it wasn't getting any better. And for the last 2 weeks, she's been really feeling that her control is not there, that her hip feels like it doesn't work right, like something, she really kept saying it feels like something got pulled out of place. And
Mhm.
and she feels like that, now it's really starting to affect her ability to raise her leg up, you know, in space, which is also a problem, but it's really impacting one-legged stance on the left. So any type of pirouettes, control, everything on the left side is impaired right now. She did go to see a PT that was associated with the group and was basically told that her TFL was tight.
Oh God.
And I know, here we go. And gave her
Oh, yay.
TFL stretches, which she feels like is aggravating the situation. So I asked her to
Oh,
demonstrate the stretch, and it was like one leg crossed over the other, and doing the full trunk side bending. And here we go with this story, Erica. You talk about this all the time. Here is a young woman who is very, very, very flexible. So the regular stretches and things, even if there was such a thing as a tight TFL, it's not going to do anything because her trunk can bend all the way over on the side. I mean, it's like,
exactly.
yeah. So this basically, she just felt like it was aggravating the hip, probably because it was making her do left hip deviation to the, left hip lateral
Yeah.
deviation. So we went through and we took a look at some things. I wanted to rule out the lumbar spine, of course, when I have anything coming down the side of the leg.
Yeah.
I always want to just rule that out, make sure that we don't have an L4, L5, something typical, especially with people who are very mobile, to get a little nerve root irritation in there. And I wanted to rule that out. So we did, full kind of just forward flexion, side bending, quadrant testing, nothing, everything didn't aggravate or flare up the hip. She does have a tendency to love to stay in a little lumbar extension. I think there's a little stiffness in the thorax, so just kind of keep that in there and kind of think about that just a little bit. And I had her do, just so we moved on, and I said, let's just look at what's meaningful here. She was really wanting to get to the bottom of it. Let's just look at one leg stance. So stand and raise your leg up. On the right, no problem whatsoever. She could, bend, she could stand there. She could bend her left knee up towards her chest. No issue whatsoever. Everything looked very nice. On the left, she immediately laterally deviates at her pelvis and internally rotates slightly.
When she does what?
When she's standing on the left leg.
I got it. Okay.
It's the left hip that's the issue.
So she deviates, say that
Yeah,
again?
she deviates laterally. So in other words, she pokes her left hip out to the side.
Got it.
And she actually has a little slide. She's trying like heck to control it, but she definitely, you can see the pelvic rotation going. So there's that internal rotation of the hip going in there, underneath there. And she does have decreased balance. She's on the lateral border of her foot when that occurs. And so we looked at that. We looked at that then in first position. We looked at it in second position, with one leg up, in the second position, develop hay, so in other words, she comes up and her leg goes up and out to the side, high as her head on, when she's standing on the right. It's not as good bringing her left leg up because she's having trouble with the pain in that left hip with that. She can do it standing on the left side. She can get her right leg all the way up. That's not an issue. The right leg isn't a problem, but her control on the left, she can't really get her pelvis up underneath her. So it she's like hanging kind of on the side there.
Yeah.
I wanted to see just a little bit about the trunk, just because I know her from her past and her history. And her trunk in the mid section of the thoracic spine is some stiffness. It wasn't bad. It wasn't a matter of, I had her stand in parallel, and we kind of played around with the thorax position, as Julie Wiebe talks about, bell ringing up or bell ringing down. She has a little bit of a tendency for kind of just the lower thoracic to, raise up anteriorly, but not bad. And it did, when we really pulled the thorax down over the, and got it balanced over the pelvis, it didn't really change what was happening in the hip. So this is probably one time where I will have to say that there really isn't an external driver here to what's going on in that left hip, because the foot, when she got the foot on the ground, that the hip still wanted to do what it was going to do. It was harder for the hip to go out laterally, but she's pretty good about keeping her big toe down on the ground, her big, toe pads down on the ground when she's working. She's been very, very well trained. She knows how to balance and hold her foot in good positions. So the foot wasn't causing the issue. The foot was because of the lateral deviation.
Yeah, yeah.
She was going out to the lateral border of her foot.
Right. And so, question though, so so when people try to laterally deviate, they'll go with their foot or their thorax. So when you try to center her via her thorax, it still caused the non-optimal movement in the left hip.
The left, it didn't cause it. The left hip continued. Yeah, it didn't fix it.
Yeah,
it didn't make it better. The foot made it a little bit better, just because you can't laterally deviate so far if your foot is on the ground.
Right.
But but it wasn't like, oh, this is it. Let's keep the foot on the ground, tape the foot. We've got it. The hip will be good, or let's make sure we've got the thorax going in the right direction here. Was it arm overhead, arm not overhead? I played around with a lot of different positions with her thorax. So we got her, into her thorax a little bit better, and then brought her arms up overhead to see it. Was it that, what was it? Was, what's, happening in here? I was looking through the whole system.
Yes.
To try to find it. The only thing I could come up with was that as she would stand on her left leg without her right, whatever ballet position she wanted to get into, she tended to move into a little lumbar extension, even if her thorax was down. So there was a little bit of that going on. So I thought, okay, well, maybe this is kind of a lumbopelvic hip thingy that's happening here. Let's see if we can tease it out. So I had her just gently exhale, bring her abs in as she did it. She still laterally deviated, but it was a little bit better. So that, but she does like to hang, you could tell that once she kind of goes out laterally deviating, she doesn't have a choice. She's going to go into lumbar extension.
Yeah, she's like she's hinging.
Yeah, exactly. And I think, but it was being driven by the hip. What's happened, the control around the hip, because her range of motion is fine. If you look at her range of motion and closed and open chain, it's fine. Yes, she has some pain there, controlling her leg going up in the air now after this has been going on for a while, but we have kind of a coordination recruitment thing going on because of this pain. Yeah. So I needed to get to the bottom of what was happening at this hip. And of course, with a dancer, she's going to sit cross-legged on the floor. Her knees are going straight down to the ground. She's not going to have your typical range of motion constraints that you're going to see in a population that isn't doing this type of performance art.
Yeah. And had she had any prior relevant injuries, Susan, to note?
No, not really. This was what she related, because I started asking her some questions at this point, especially because she was having trouble standing on her left leg, and she was having trouble concomitantly with open chain left second position developpe.
Yes.
And so I got curious. I said, what did you do last year? What part did you have? And she goes, it's interesting that you're asking me that, because the entire last spring I was the Lilac Fairy in Sleeping Beauty. And she goes, so it was all about, and the Lilac Fairy has like 100 second position developpes from the back of the stage to the front of the stage. It's like the premier thing that the Lilac Fairy does.
Update my Sleeping Beauty knowledge.
Yeah, I know, right? But this is interesting because, I don't know. Did she? Yeah, it's a movement pattern. Was there a compensatory adaptation in there? Probably. But the idea is, what she was left with is like, she said, that, so it was off and on a little bit, like on the verge, during that whole time. But then it was like big, now it's kind of big time.
Yeah. And it's interesting because the reason, the movement that got her in your door was that she was in a kneeling, half kneel position. Yeah. The foot was out of the picture theoretically, and it was more like really like above the hip and pelvis, so hip and pelvis and above. Mm-hmm.
Yeah, but it was and was it that she was deviating and half kneeling?
Yes.
And that's what made her, things kind of change, or that was just the final movement piece where the system finally said, that's it, we're over recruiting now, we're not going to do this anymore.
Right, and her system, her thorax, could take her back, but it sounds like her hip was the one that was really trying to struggle to get her more midline than the thorax.
So then we hadn't done this yet because we were looking at one leg, on standing one leg with the other leg in various positions, just trying to playing with the thorax, playing with the arms, really trying to make sure it wasn't a foot driver or a thorax driver, noticing the bit of the lumbar, kind of sitting into a little bit of lumbar extension on that side. And I said, what else is problematic? And she goes, I have trouble getting into fifth position. So and that makes sense because it's hard to externally rotate for her. Yeah. She's favoring or moving or biasing into a little bit of internal rotation. Mm-hmm. And again, for somebody else that could be fine, but for somebody who's performance based that needs to have this position, it's not fine. Yeah. She's fighting it. So the only way she could slide into fifth position and really achieve fifth position was to put her, bend her knees into a plie, put her feet together in fifth position and straighten up. She could not just come from like first to fifth, like she couldn't, or fourth to fifth or any of those types of things. She was missing about 15 degrees of that back heel coming into position there. So we use that as a retest because I thought, okay, if we get on the right track here, she should be able to achieve fifth position. And if she can do that, then that can be her retest to know if she got out or, if whatever she did made things worse. I wanted to have a test position for her because she was going right back to class the next day. Yeah. And, so we went through a series of things for her to work on. And one of the things that I wanted her to be able to do was see if she could get her hip to stop laterally deviating. And whenever she was standing on one leg and so she was standing on her left leg and trying to come out of lateral deviation. So in other words, she needed to abduct her left hip under the pelvis, right? She needed, the hip pelvis, we needed to abduct in order to get it out of that position. Yeah. So she needed to fire her, her medial, her abductor muscles. Yeah. And she was having a devil of a time doing it without firing her lumbar extensors as well. So the lumbar extensors were trying to take over to do this stuff. This is what I was starting to discover with her. So I actually had her put her foot up on, she was in her apartment room and I said, put your foot up on a chair, so that you're in more than 90 degrees flexion on the right. So she's standing on the left, put the right foot up on a chair.
Passively,
yeah. A sense of, to just take her, and so her right hip was basically at like 110 degrees flexion. Got it. With her foot on the chair, right? Yeah. So you can get the picture that basically what I was trying to do was inhibit the ability of the lumbar spine to extend so that she could start to target the hip to pull her out of lateral deviation. And she was able to do the movement.
Oh, nice.
So that was really, really interesting to me. It's like, okay, if we eliminate the easy access to the lumbar spine extension, now if she's going to do this movement, she has no choice. It has to come from this area.
Yeah. And could she do it easily, or was it hard?
No, she could do it. It came pretty easily. Yeah. So what we did was we chose this to be her reset exercise. Mm-hmm. So we did it a number of times and till she could get the feeling and do the stuff. And then we went back to retest fifth position. Yeah. And she was able to get into fifth position a little bit better, but she was still complaining that this kind of point tenderness right behind the trochanter. So I basically told her to get out her K-tape. Mm-hmm. She cut it down, I told her about how long, she measured it. She knows how to put tape on. Yeah. And she knows why we're doing it. So, and I told her, I said, I want you to go into the other room and you're going to have to, get onto your pelvis here. But I want you to take that tape and I want you to put it just below that point where you're pointing. Mm-hmm. And I want you to bring it up at an angle coming up towards your, the pelvic crest, basically. Mm-hmm. So I said, go do that. She did. She came back into the room. She was smiling. It feels so good. And I said, okay, where else do you feel like you need it? She said, I feel like I need one coming from that point, but coming more forward, towards the ASIS. Yeah. So basically what we were doing, we're trying to recruit so that the taping, the way we were putting it into that position was to help sensory wise tell the muscle it's okay to work here. Yeah. That there's support there, so that, then get the proprioception in through the skin to get those muscles on the side to fire up. Mm-hmm. and not have, because I could have gone in and tried to go across the lumbar spine and try to inhibit that. I
Yes.
just felt like it was so much more accessible on the hip, especially since that was the exercise we were doing.
Yeah.
Put the tape on, she could stand on one leg and she could actually stop the deviation.
Yeah.
So that helped. So immediately that worked, and she could go right into fifth position.
Yeah. So you gave her the ability to access a better movement pattern.
Yeah.
Yeah.
And she got the sensory support. I'm saying sensory, everybody. This,
Yeah.
the sensory input support that gave her the confidence, her motor system, the confidence to change.
Yes, yes, it facilitated. It's facilitator. Tape's
Yeah.
a facilitator.
Yeah.
Yeah.
So, and off she went, and she was going. So we got back together 3 days later. So much better. But now she really wants to concentrate because she can tell. She goes, I can tell my left hip is not working as well as my right hip. So I want to have some things to kind of, move this forward now. So, and she loved the idea of going back to checking fifth position because she could tell after she was doing some center floor stuff that she couldn't achieve fifth as well after she did. And so she used that, she put her foot up on, she said, I put my foot up on the, on a chair, and I did the exercise, and then I could achieve fifth again, and I knew I was okay.
Good.
So yeah, so having that retest and reset can be so helpful. So, but now we need to, if the hip is the driver, as you always say, now it's time to load it. Because otherwise she's not going to go anywhere further, So basically we did, we got out the TheraBand, and we did some TheraBand glides to increase leg rotation. So she basically did, like she would take the TheraBand and she put it on her foot, and she would move her foot in and out of rotation, both directions. So we could get, no, we were standing. Sorry.
Standing.
All of these were standing. Yeah.
Okay. So how did she do that then?
Yeah. So she would stand, she had the TheraBand, tied to something, and she put her foot in the loop.
Yep.
So that she could stand and work towards going from first position to parallel, and then she could work from going from parallel to first position.
Got it.
So we can get the rotators back and forth.
Yeah.
We did some partial squats, to, with cueing plies in the different positions where she put the TheraBand around the thighs. So we basically went into, all of the positions, to where she had the TheraBand around the thighs, and her cue was just to kind of just roll out against the TheraBand on both sides. So we could keep it, sensory specific. And then we actually dropped down and put that, and I don't usually do this with people right away, but she was doing really well, and she knew how to retest herself if something didn't go well. Usually I keep it up around the thighs in the beginning until they get better control, but this time I decided to let her go down and put the TheraBand around her ankles. And we did some gently, kind of doing, they're called in ballet rondejams, but basically they're circles on the floor with your feet, going back around to front, going front around to back. She did really well with that. So we added the brushing into first, from first forward, first, lateral, first back, and did some of those on both legs.
Yes.
Because she needed to gain the control with single leg stance on the left, as well as open chain control on the left.
Yes.
And she was having problems in both closed chain and open chain.
Yes. And you also get that neuromuscular crosstalk between the two limbs.
Exactly. So we're crossing midline.
Yeah.
And really getting the input from one side to the other, so that this is how it should feel here. This is how it should feel here. Does it feel the same? Can we make it feel the same? So she was getting that input rather than I just feel my hip. I just feel my hip. I just feel my hip.
Yeah.
And then the other one that we did was that she was having trouble with was the second position developpe. Remember the lilac fairy?
Yeah.
And so she was able to brush out and up into full developpe, but on the way down, she would feel her hip. That's when it would kick in. Like, oh, I feel that now on the way down. So we basically just did the full brush up, then allowed her bend her knee so her foot came towards her thigh, and then slide her foot down her leg to return.
Okay.
After she did that a few times, she was able to do a full brush up and a full brush down. So her homework was to do these, but go back to your retest and make sure you're okay.
Yes, yes,
You
yes.
know, and she, so I checked in with her actually a couple of days ago, and she is doing beautifully.
That's great.
No problems whatsoever. So these performance artists are quick to treat,
Yeah,
but they're tricky because they're so mobile.
yeah.
They will fool you every time if you don't look at the pieces and the parts and really
Mhm.
try to look at it in a way that is like, oh, I'm just kind of seeing this a little bit like this instead of like that. But it was interesting because I really, my go-to things to rule out is basically the thorax and the foot when it comes to the hip.
Yeah,
You
yeah.
know, it really is. But and for performance artists such as hers, classical ballet, you got to have the one-legged stance. You've got to have the full open chain flexibility.
Yeah,
So it's a
yeah,
combination of control and full free, movement.
yeah.
And when something gets overworked, like with her, perhaps because of doing an entire spring season of Sleeping Beauty and being the Lilac Fairy, and that was the
Yeah.
performance movement she did day after day, night after night. It just, her body just finally said that we can't do that anymore.
Wonderful options.
We're gonna,
I
yeah,
like
we're
that
gonna,
because usually when you have like that AP sort of translation hinge or whatever you want to,
uh-huh.
usually correcting the thorax or sort of neutralizing or putting in a better, it helps a lot. But it's interesting, that didn't work with her, and you wonder,
Mhm.
what do you think was driving the hinging? Was it just the control in the hip that she
I
needed
think
a?
it was a control in the hip that I
Yeah,
think she had done that movement so many times that her,
yeah.
she probably was beginning to compensate
Ah, right, 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 right.
as she was going through. She was probably working through some minor injuries, as everybody does. It's performance,
Yeah,
and just wasn't paying it, because she said off and on it was bothering her, but not enough to make her stop.
yeah, yeah, yeah.
So there were things happening, and I think probably what ended up finally happening was, we can adapt until we can't, and
Right.
and at
Yeah.
that point, the protective brain probably took over and said, stop, we're going to stop you from doing that.
Right, right,
That's
exactly.
too much. We're going to
Yeah,
stop you from doing that.
yeah,
You're getting some small, maybe she's had, I didn't have an ultrasound machine, so I couldn't really check to see if she had like some micro tears or some
yeah,
thickening. I mean, she's 20, so I just think she probably had a little bit of a little bit of a tendonitis that was starting to set up in there, or
yeah,
maybe
yeah,
did, but it was, finally just enough that it made her feel like she didn't have, it gave her the feeling that she was out of place, which always tells me that there is a over recruitment, under recruitment, discoordination issue going on, which is
yeah,
why people feel out of place,
yeah, yeah. And
because things
I
don't
like
move the way they're supposed to. Yeah.
exactly, exactly. And I like the way when you put the foot on the chair, you take away the compensation and the reality unfolds, literally,
Yeah.
right? And that's when you find out, oh, I can actually do this if I take this compensation out, or I can't do this. It can go either way. Like if there was a true strength hold, but with her, there was no true strength hold. She just wasn't facilitating optimal movement when she was in that hinge position. So
Right.
the reset is a great way to give people, not just dancers, but anybody, empowering them to actually train their brains pretty continually without coming in every single day to see a physical therapist, right? You want to give them tools that they can use, especially dancers, because they need to keep working, right? I mean,
Mm-hmm.
reality of the field, unfortunately.
Yes. And that, yeah. So anyway, I just thought that was
That was
interesting because it
awesome.
was not the usual kinds of things that I expect to
Yeah,
see, but it was also a lot of fun to, put on the
yeah,
curiosity cap and say, I wonder, let's play around with this and see what we figure out. And I think 90% of the time that's what we do, right, Erica? Is
yeah,
we get curious, like, well, put your foot here and try to do this.
right.
Okay.
Change the system some
Yeah.
way.
But giving her clam, what a
Self
clamshells,
stretch, oh my God help me.
are trying to stretch a TFL. I mean,
Ay, ay, oh,
it just,
so
and
many
then
moving
watching
parts.
them do it, it's like, okay, there's, this isn't,
Oh
That
yeah.
wasn't the issue. The issue was the control issue, and possibly ruling out that something else was going on, but
Yeah.
she was good. It was just these extreme types of positions that her performance craft requires were
Yeah.
not good. But like just walking around and going up and down stairs, and she was fine. It was
Yeah.
when she was like having to get into the range of motions with the control and the need for flexibility that she wasn't fine in that area.
Yeah, and just to wrap up, the TFL stretch the clamshells. It's like that's not clinical reasoning. We've talked about this so many times.
Mm-hmm.
You need to look at the whole person, the whole movement system, and really kind of think out of the box, right? And maybe it is the hip issue, but try to put the patient in a position where you can see what their strategies are, whether it's
Yeah.
optimal or not optimal. You need to change something.
Mm-hmm.
So, and just giving them a stretch and an X strengthening, that precludes the fact that you've done your assessment and you assume that there's a tight TFL and that there's a weak hip. And my guess is that was not done prior. So don't even get me started. I could go on and on and on, and I won't. Anyway, lovely case, Susan. That was great.
Okay, everybody.
Enjoy.
Yep. We'll see you soon on the next podcast.
Next episode.